Assalamualaikum.
Waalaikumsalam. Okay.
Okay. Mula dengan Al-Fatihah. Sekejap. Ni apa kes? Ni kelas apa? Case discussion apa?
The case discussion.
So you guys present case lah kan? Okay. Okay, sekarang start. Sekejap. You guys fifth year kan?
Betul.
Sekejap ni. Sekejap. Bukan kata tak ada slides ke?
Doktor tak cakap apa pasal slide. Kayaknya doktor tak nak slide ni.
Confused lah. I ingat bukan dengan you guys kan. Kata yang presenter tu kena tak boleh tengok slide, tak tengok kertas, tak boleh tengok apa-apa, you kena present verbally, standing. I rasa group you kan? Bukan group ni ke?
Tak ada yang saya WhatsApp doktor tanya perlu prepare slide macam doktor cakap okey je.
Yalah. Sebab dulu I dah confused lah sekarang sebab dulu macam third year dengan fifth year ni kelas lain sikit. Sekarang ni third year ada case discussion, fifth year pun ada case discussion. So dia jadi macam tak jadi confused. I rasa macam I cakap dengan you guys. Tak apalah. Macam tu guna present slide.
Tak payah doktor. Tapi ni from case write up lah doktor. Kita orang tak sempat nak clear masa week first.
Itulah. Tak apalah. Boleh lah. Dah lah. Okay. Okay, proceed.
Okay. So bismillahirrahmanirrahim. We will start with first case discussion. Okay, next. Next. My patient, Sharah, a 5-year-old Malay girl with no medical illness, was referred to emergency department of HTAA due to rashes and pain over the right foot on the day of admission. Initially, next, she was apparently well until the day of admission, where she complained of pain at the dorsal aspect of the right foot, which is around 3 p.m. She was unable to describe the character of the pain. However, it was localized, not radiating, and there was no relieving factor. The pain was exacerbated by walking. The pain was also associated with swelling overlying the right foot. However, there was no skin changes such as erythema or discharge. Initially, mother thought that it was just a normal sprain because the patient had history of fall during playing at the kindergarten 3 hours prior to the onset of the pain and swelling. On further questioning, she had history of fever a week prior to the onset of symptoms. However, there was no other URTI, upper respiratory tract infection symptoms such as a runny nose or cough. And then the fever resolved spontaneously after being given syrup paracetamol. Next. Due to the pain and swelling, patient was brought to Klinik Kesihatan Bukit Sekila at around 6 p.m. on the same day. At that time, patient can still walk. However, in the clinic, the attending doctor noticed that there was rashes of pinpoint size at the dorsal aspect of the right foot, which parents did not notice at home. The rashes were purplish red in color and only involved the foot area. Patient was referred to emergency department HTAA for further workup throughout fracture and to investigate the cause of the rashes. Upon arriving at HTA around 8 p.m., parents noticed that the rashes already extend to the distal midsection, with the smallest size is pin-like and the largest about size of 5 cents coin. At this time, the rashes already involved both of the foot and patient unable to walk. Patient then was put on diapers. Next. Next slide ni. Okay, for the question ni, there was she denied any hematuria, abdominal pain, bradycardia or melena. There was no neck stiffness, fever, photophobia, headache, project badminton, and history of seizure. There was also no bleeding tendency such as epistaxis, gum bleeding, and there was no bruises all over the body. There was no constitutional symptoms such as loss of appetite, loss of weight, night sweats, or chronic fever. There was also no family history of blood disorder or blood malignancy. She had no symptoms of systemic lupus erythematosus such as rash on the face, chest pain, shortness of breath, or anemic symptoms such as palpitation and dizziness. Okay, next. So on the second day of admission, patient started to develop joint pain involving the right knee. She refused to move the joint, and the rashes on the lower limb seems to be resolving and the color also faded. Patient was then given ibuprofen. There was no genitourinary or gastrointestinal involvement such as hematuria and abdominal pain respectively. On the third day of admission, patient developed rashes over the upper limb. The rash size vary from 50 cents. The rash size on the upper limb was about 50 cents size, overlying the right elbow with right elbow pain, and there was also new rashes noticed at the middle aspect of right and left thigh. Okay, next. So for further history, she had no non-medical illness. However, there was two history of admission to the hospital during 2 years old due to right shin abscess. Patient was then treated with incision and drainage. And the second admission was during at 4 years old due to bronchopneumonia. And patient was discharged well. There was no sequelae and complication due to the admission. And then patient was not having any non-drug allergy, not on any medication, including traditional medicine. There was also no over-the-counter drug prescription. And next. So for birth history, she was born at term at 40 weeks today by vaginal delivery and on induction of labor. The birth weight was 3.45 kilogram. Antenatally, her mother had gestational diabetes mellitus on diet control. Postpartum, she was admitted to neonatal ICU for 1 day duration due to rapid bleeding. She also had a history of neonatal jaundice for 1 week. However, it was not requiring any phototherapy and was treated as outpatient. Okay, next. So she was exclusively breastfed until 6 months old. Weaning started at 6 months old, and currently patient was on adult diet. She is a picky eater, did not eat vegetables and only eat fruits as the source of fiber. Her normal diet consists of quarter to half plate of rice with chicken or fish and fruits. She had no non-food allergy, and her growth is normal as claimed by the mother. Next. For immunization history, it was completed up to her age. Developmental is up to her age. Currently, she can walk and run well, can jump, can use scissors well, can write her own name, and can draw human. She also can speak well with multiple vocabulary in full sentences. She also can undress and dress and socialize well with her friends in the kindergarten. Next. So she is the only child in the family. There was no non-medical illness among family members. There was also no non-family history of autoimmune or blood disorder, no consanguinity marriage between parents. As for social, patient lived in Kampung Padang in a rent house with three family members. Her father is a businessman while mother is a kindergarten teacher. Their total income was about 3,500 per month, and her father is not a smoker. So upon physical examination, it was done on the third day of admission. Patient was generally conscious and alert. She was not in respiratory distress, but appeared in pain by evidence of restriction of the movement of her lower limbs. Hydration status was good, evidenced by moist mucous membrane. Nutritional status was appropriate for her age. There was granula attached to the right dorsal hand with no active infusion. On the peripheral examination, the hands were warm to touch and capillary refill time was less than 2 seconds with no palmar pallor. Eye examination revealed no conjunctival pallor, no jaundice or decay. There was no central sinuses and no petechiae or evidence of gum bleeding. There was also no palpable lymph and no pedal edema. Next. So for the musculoskeletal examination, on the lower limb examination, there was multiple rashes which involved the bilateral lower limb from leg extending to the mid-shin, which is the mixture of petechiae and purpura. The rashes was purplish in color, raised and palpable, with well-demarcated border. The rashes was multiple in size, ranging from pin-like size to the big and to the biggest is peanut size. The rashes was non-blanchable. There was also new lesion noticed at the middle aspect of bilateral thigh with the same characteristic as mentioned above. She had limited range of motion for right knee joints. However, there was no local signs of inflammation such as swelling or redness over the joint. Other joints were normal. And upon the examination of the upper limb, there was one new arising lesion on the right elbow, which size of 50 cents coin, purplish in color, raised, palpable with well demarcated border. The right elbow also has limited range of motion. However, other upper limb joints are normal. Otherwise, the trunk is spread. Okay, next. So in summary, my patient, a 5-year-old Malay girl with no non-medical illness, was presented to emergency department of HTAA with right foot pain associated with swelling and rashes, which extend to the bilateral leg with refusal of weight bearing. However, deny any abdominal pain or hematuria. And on physical examination, there were multiple non-blanching purplish rashes ranging from pinpoint size to peanut size over the lower limb and upper limbs, with limited range of movement over the right knee and ankle joint. Hernia and bruising signs were negative. My provisional diagnosis was herniated scaling purpura with skin and joint manifestation because the she was presented with purpura over limbs, usually at the dependent areas such as lower limbs, buttocks, face, but spare the trunk and face. She also had arthralgia, which she refused to wet bear. Had a history of fever, which could be the trigger for this presentation. And she was 5 years old, which is the common age to get HSP. And the pattern of rash itself is raised, palpable purpuric rash. And she also complained of pain and swelling, which might be arthritis. So other differential would be meningococemia due to patient present had history of fever, and there is also the non-blanching purpura. However, there was no other signs of meningism such as headache, photophobia or neck stiffness. Second one could be immune thrombocytopenic purpura due to the rashes itself. However, patient had no fever, lymphadenopathy, or history of easy bruising or bleeding. Third one, leukemia, specifically acute lymphoblastic leukemia, which is common in children. And then systemic lupus erythematosus with thrombocytopenia, because patient had joint pain, history of fever, and also rashes. However, there was no other symptoms of systemic lupus erythematosus. So next. Next. There were several investigation which can be done to confirm the diagnosis and rule out other differential. So first, I would like to do blood investigation such as whole blood count to look for white cell count for evidence of infection. And then I would like to look for hemoglobin level if there is any anemia, and also the red cell indices to know type of the anemia. And then the important one is to look for platelet level, because in HSP, the platelet level could be normal or increased, which is different in ITP, which is due to thrombocytopenia. Okay. Second one is renal profile, because in HSP, it can involve the renal, which result in nephritis. So I would like to look for any evidence of kidney injury by looking at the urea and creatinine, and also any electrolyte imbalance. And then I would like to do urine pool examination and microscopic examination to look for any red cell cast, white cell, if there is any infection, which could be due to HSP or autoimmune thrombocytopenic purpura. And then next. I would like to do a C-reactive protein to look for ongoing inflammation. So it is a good marker for monitoring progression of the disease as well. And other investigation which can be done is complement level, because one of the differential is SLE with thrombocytopenia. So complement in SLE, the complement level will be reduced. And then next, we can consider serum IgA, because HSP is IgA mediated. So serum IgA might be raised in this patient. And then for occult blood, if there is any gastrointestinal involvement, so patient can present with occult bleed. And then coagulation profile to rule out any bleeding disorder. Next. So for HSP, the aim of management is to control the symptom and supportive. So for the joint pain, we can give per oral ibuprofen 180 mg 8 hourly to relieve the joint pain. And we can monitor the circulation chart of the bilateral lower limbs and straight input output charting, and also encourage orally. So usually HSP had good prognosis and resolve spontaneously. However, we need to monitor for the complication of renal, because it can progress to end-stage renal failure. I think that's all for first case.
Okay, any question? Any questions, anyone? Saya susah sikit lah nak tanya. So, I tak nak sangat this kind of presentation sebab problem dia this is someone else. So kalau I tanya you something about the history kan, I nak tanya something yang you miss from the history, you tak boleh jawab pun sebab it's not your case kan. Okay, so anyone got any questions?
Doctor,
Oh.
Can we still put dengue as a differential diagnosis for this patient?
Tanya Syazwani, boleh tak? Syazwani, boleh tak? Can you put dengue as differential?
For me, less likely because of the pattern of the rash itself. Because here patient presented with palpable rashes, but in dengue the rash is usually non-palpable, and also currently patient had no fever, so less likely, but it could be.
I don't think so lah. I rasa you need a strong justification untuk tak dengue as differential. Top of the list would be HSP lah. Second would be meningococcal septicemia. And then you boleh kata some other vasculitis lah. Even kalau you kata this is JIA ke, ada rheumatology tinggi kan, macam rheumatic fever ke, I think it's more acceptable daripada dengue lah, I rasa. I personally, that's what I think.
Okay, thank you, Doctor.
Okay. Itulah. Rasa macam semua dah complete. Ada soalan lain?
Doktor, nak tanya pasal complication of HSP. Common ke if children will come with intussusception, so bloody stool?
Syazwani, is it common? Common tak, Syazwani?
The most common yang involve for HSP, renal and GIT lah. But yang saya baca dia macam tak adalah percentage dia tinggi sangat, cuma tapi kita still watch out sebab intersection ni dia can lead to perforation. So dia boleh jadi fatal, sebab itulah macam boleh tanya lah untuk assess the complication.
So macam tu lah, I pun tak tahu dia percentage tapi that's one of the complication lah yang you kena watch out. But when will you need to treat? Okay, in terms kejap. Rasa ada orang nak rancang lain kejap. Yes, go. Okay, nak tanya your opinion. Tadi apa soalan tadi? Complication kan? Okay. So that's one of the complication lah. And you have to remember, the complication ni occur at the late stage tau. Dia bukan occur at the beginning. So usually after rashes tu dah stable kan, dah flatten semua. And then patient even sometimes after the pain goes, gone kan, after the pain gone, then only you get the complication. So it may come later. In fact, a lot of case, you bagi ibuprofen and then dia settle and then you discharge and then patient datang dengan abdomen pain, IO and also interception semua tu lah. Compare to renal punya complication. Renal punya complication, dia is a long term complication. So when you talk about complication, you divide into like early immediate punya complication, short term and long term punya complication kan. So renal is actually long term punya complication, and this is occur in the patient with hematuria. That's why you check hematuria from beginning. Kalau patient tak ada hematuria, then usually you tak worry lah. Tapi kalau dia ada hematuria, then you need to monitor, you need to follow up. Okay. I nak your opinion. What you think can actually improve the session? Because I don't think it's beneficial lah to present other people punya case write up and then in slides. So I don't find this session beneficial lah for you guys, and even maybe for myself. Any opinion? Any suggestion for improvement?
Maybe we could do a live plugging session, like the doctor would be the patient and us would be doctor.
Okay, maybe next time kita boleh buat macam tu lah kalau you nak. Cuma the problem is as fifth year kan, the focus would not be on your clerking skill lah. It's actually more on your management and your thinking. We're assessing your thinking, your problem solving, things like that, rather than clerking. Tapi kita boleh buat that session. Tapi the focus still would be the the management and also the problem solving punya aspect. Tapi next time kita boleh buat macam tu. So besides that, what I did kan for third year, so like you guys jangan tak ada case, so I asked them to plug my MOs. So we've got patient dekat ward kan, so I asked them to call my MOs and plug them. So my MOs will present get the history lah, and then present the clerking. But for third years, the focus is on the clerking, issue taking on, and also presentation. For fifth year, it's actually more on like problem solving lah. But we can do that lah. We can do that. I think next session maybe kita boleh buat macam tu. So you plug me and then we discuss. Okay. Besides that, okay, apa lagi? That's one good idea lah. Okay. Anyone else? By the way, kita ada another presentation kan? One more kan?
Yes, Doctor.
Okay, for the next one, kita buat cara lain. Okay. I suggest what we can do. You akan present Marahini, you present. Okay?
Yes, Doctor.
Okay. So I don't want you to present your slides. Okay. Okay, give us a stem. Okay, just give a brief introduction of the case, like 1 or 2 sentences. For example, macam you are a medical officer, macam examnya style lah. You are a medical officer at general pediatric ward. A mother came with a 5-year-old daughter with complaint of abdominal distension. Okay. So I want each of us, okay, each of you, I will call names, okay, and take turn to plug the case. At the end, the lucky person will make the diagnosis, and then we discuss. Okay, boleh tak? I think that's more challenging lah rather than doing a presentation.
Boleh, Doctor.
Okay. So okay, Mani, give us the brief introduction.
Okay, this is a case of 11 years old boy came with his mother
actually he presented to the pediatric clinic in view of high blood glucose level that noticed 1 month for 1 month duration prior to the admission.
Okay, good. Okay, so I'll call names. Sekejap. Huh? Oh, kena call name dulu ni. Sekejap. Hold on. Sekejap. Okay, let's start. So Aimi Soleha, what do you want to ask? You ask first. Semua kena dengar properly, kena dengar attentively because the last person you akan kena buat diagnosis and then you kena justify kenapa you make that diagnosis. And then kita akan tanya ada differential diagnosis and you have to justify. Or a better, maybe one of you akan summarize the case. So Aimi Soleha, start first. You tanya soalan lah.
Okay, yes, doktor. Doktor tanya bahasa Malay ke in English?
Doesn't matter. Ni tanya the mother.
Okay. Boleh ke saya tahu kenapa bawa tu because of high glucose level tu, macam mana dapat tahu?
Oh, sebab sebenarnya 2 bulan sebelum masuk ni anak saya ni ada macam apa, swelling dekat belakang dia, dekat belah kiri bahu. Lepas tu swelling tu dia mengadu gatal juga. Lepas tu sakit juga tapi dia tak demam. So lepas sebab swelling tu lah saya bawa pergi klinik.
Okay, Ami? Oh, okay ya? Nak tanya soalan?
Okay,
tak
okay,
tak apa.
Okey je doktor.
Okay, Syami.
Apa?
You make sure the flow, dia kena ada flow Tak nak tanya tiba-tiba tanya, oh ada demam tak? No, you kena tanya tadi pasal swelling kan. Then you kena tanya continuous, questions. Continuity to the first question
Sebelum bengkak tu dia ada jatuh-jatuh ataupun kena pukul ke dekat area situ?
Tak ada jatuh pun, saya tak pukul lah anak saya.
Okay, Arif Mustaqim.
Pasal bengkak tu, dia membesar dengan cepat ke dia sama je saiz dia daripada awal?
Dia besar tapi tak cepat lah, dia macam gradual je.
Okay, Ashraf Harin.
Bengkak tu ada keluar nanah ke atau keluar apa-apa cahaya ke?
Tak ada keluar nanah pun, cuma dia merah dekat tempat tu.
Oh, okey. Sakit lah.
Sakit kalau sentuh.
Fadila Nasha.
Bila bengkak tu ada buat apa-apa tak?
Yang 1 bulan tu macam sebab dia slow, jadi macam ingatkan sebab biasa kena gigit nyamuk je. Lepas tu sebab tak hilang-hilang, lepas tu dia membesar. Sebulan lepas tu baru saya bawa pergi klinik.
Okay, sekarang biar saya tanya soalan. So Puan, apa kena mengena bengkak ni dengan cek gula?
Ambil gula dia. Lepas tu doktor kata bacaan dia tu tinggi.
Oh, okay. Okay, next. Faiz Aiman.
Puan perasan tak anak macam cepat dahaga ke banyak air? Puan?
Dia cepat dahaga lah. Dia minum sekarang ni macam banyak sangat air. Macam dalam 3 liter sehari. Tapi sebab dia aktif. Tak tahulah sebab aktif ke. Tapi memang ada masalah lain.
Sebelum ni dia ada banyak kena jangkitan macam ni juga tak?
Tak pernah.
Tak ada lah.
Tak ada.
Kencing? Kencing dia ada banyak kali kencing?
Tak ada pula. Sama je macam sebelum ni.
Kerap bangun kencing, bangun malam untuk buang air ke?
Tak ada.
Tak ada ada dia cepat penat? Tak?
Tak ada. Dia memang aktif.
Dia memang aktif berat badan dia macam mana? Ada berubah?
Berat badan dia tak ada berubah, cuma dia memang besar.
Oh, dia
memang
besar.
gemuk. Tak nak tanya ke berat dia berapa?
Berat dia?
Berat dia 95 kilo.
95 kilo?
Kilogram,
dia
ya.
11 tahun?
Ya.
95. Oh.
Okay, good.
Memang
Farisha pula. Farisha saya saran. Bagus. Ada yang Farisha?
Ada. Tapi dia aktif kan? Sebelum ni memang berat badan dia macam tu ke? Ataupun tiba-tiba berat badan dia naik?
Dia dah memang besar dari 5-6 tahun memang dah besar.
Ikhlas?
Dia tak ada tiba-tiba naik.
Okay.
Tinggi dia berapa ya? 7 cm.
27.
157.
Okay. Is Hilmi. Ikhlas Soleha.
Ikhlas dah doktor.
Oh dah. Is Hilmi.
Macam mana dengan pemakanan harian dia?
Dia makan macam orang biasalah. Sehari 3 kali makan. Lepas tu makan nasi pagi untuk tengah hari, petang, malam macam. Tapi dia tak suka sangat sayur.
Izzatul Husna.
Ada ambil apa-apa ubat tak, macam ubat steroid ke sebelum ni?
Steroid tak ada. Tapi dia memang ada makan ubat lah untuk penyakit.
Ubat apa ya yang dia ambil sekarang?
Ubat darah tinggi.
Okay, Luqman Sabarani.
Tadi ada Puan cakap yang pergi ke klinik tu kan, lepas dia punya bengkak tu makin membesar. Saya nak tanya dekat situ, doktor ada bagi ubat jangkitan kuman ke? Apa yang doktor buat untuk kurangkan surut?
Ada. Untuk yang masalah bengkak tu lepas doktor bagi antibiotik, bengkak tu dah surut dah. Lepas doktor tu kat klinik tu bagi ubat antibiotik, lepas tu surut, dia bagi surat macam refer dekat hospital untuk masalah yang gula dia tinggi.
Okay, Masyafizul Jamil. Last soalan.
Apa ni, saya pada simptom tu ada tak dia cakap pasal apa, dia ada rasa berdebar-debar ke? Ada tak?
Tak ada.
Berdebar-debar, berit ke ataupun berpeluh sangat ke?
Tak ada. Semua tu tak ada.
Okay.
Okay, good. Okay, so semua ingat kan soalan-soalan tu? Okay, now Najira Jamaluddin, you kena examine the child. So, you start tu. So, you tanya the mother, anything yang you nak tahu. Contoh you tanya, dia alert ke tak? Macam tu. Benda macam tu lah contoh. Okay, Najira.
Okay, patient adik ni ada sakit tak kat mana-mana?
Sekarang ni tak ada. Tak ada sakit kat mana-mana. Boleh duduk.
Dia alert ke?
Boleh cakap semua.
Ada macam sesak nafas ke?
Tak ada.
Dari segi muka dia ada tak macam sindromik?
Sindromik tu apa?
Ada tak nampak macam dia punya muka macam Down syndrome sikit? Maksudnya macam dari segi mata dia macam cakap
Tak ada. Muka dia biasa je.
Tangan dia ada tak macam berpeluh?
Tak berpeluh.
Dia punya tangan tu ada tak macam sejuk ke sama je, warm?
Tak sejuk pun, warm je. Kan tangan.
Okay, Natasha Nasir.
Okay. Kalau kita tekan tangan dia tu, dia senang tak nak apa ni panggil nak refill balik darah tu?
Senang.
Okay. Dia ada ni tak biru-biru kat tangan?
Tak ada biru.
Ada merah-merah kat tangan ke?
Merah pun tak ada.
Okay. Dia ada ni tak ketar-ketar kalau tangan dia?
Tak ada.
Okay, Aisyah Ramli.
Okay.
Bagi siapa yang betul.
Kalau bahagian muka dia kan, dia mata dia ada nampak pucat ke? Pucat ke, kuning ke?
Tak pucat, tak kuning.
Okay, kalau dekat belakang tengkuk dia ada macam hitam-hitam gitu tak?
Itulah ada macam perasaan dia pelik sikit dia seorang ni, ada macam hitam-hitam macam tu. Kat belakang leher.
Adik-beradik dia tak ada lah. Dia seorang je. Dah berapa lama tu?
Dia seorang. Dah berapa lama? Dah lama lah. Dalam 2-3 tahun ni. Kita dah kecil tak ingat lah.
Okay, good. Noha, ada soalan? Examination.
Hello. Dia dekat tengkuk dia macam ada nampak bengkak ke? Macam besar sikit. Hello, dengar ke?
Dekat tepi ke, depan ke, belakang ke apa?
Saya nak tanya buffalo hum tu. Dekat belakang.
Belakang. Ada ke tak? Marhaini ada?
Ini tak ada.
Kedua ke? Okey, tak apa lagi. Soalan apa lagi nak tanya?
Saya nak tanya kalau dia ada scratch mark, contoh ada gatal-gatal ke?
Okey. Tak ada. Buffalo hum pun tak ada. Marhani,
Yes, sorry doktor.
Nuha tanya, ada buffalo hum ke?
Tak ada.
Tak ada. Ada scratch mark?
Tak ada.
Tak ada. Okey. Lagi? Nur Alia Najwa.
Ada macam bengkak ketulan kecil-kecil ke dekat leher ada?
Ketulan kecil-kecil dekat leher, belah mana tu? Depan ke belakang?
Dekat depan.
Oh, tak ada.
Benda apa ni?
Lymphadenopathy.
Okey. Okey, tak apa. Okey. Okey, Nur Fatihah Fatihah Ahmad Yasin. Okey, Cak.
Saya kalau dari segi pernafasan, berapa dia punya respiratory rate dia?
Oh, kalau tengoklah dia bernafas tu kira dalam 23.
Suhu badan okey ke tak? Demam ke?
Tak demam pun. Normal je.
Pulse rate?
Pulse rate 90 beats per minute.
Okey. Fazira, last soalan.
Yang nak tanya, selalu tak adik ni dapat jangkitan ke ataupun kata-kata ke di celah pelipat, ada ke?
Tak ada.
Lagi. Okay, lagi ada soalan lagi. Ada 2 lagi benda yang I nak tahu. Tak siapa nak tahu BP dia ke? BP dia apa BP dia?
BP dia 128/65 millimeter mercury.
Okay. So Khatijah Al-Balkhis. Soalan?
Saya nak tahu berapa kulit pinggang dia?
Susah.
Kulit pinggang dia tak ada lah
berapa
dalam
seluar
ni.
dia? Seluar dia saiz berapa? Tak tahu.
Dia dah mention dalam kes ni.
Okey, tak apa. Next. Saya salin tu, soalan.
Mak ayah dia ada sejarah keluarga kencing manis ke?
Oh, ayah dia ada kencing manis, ada darah tinggi. Dah lama dah. Ada masalah buah pinggang sekali.
Mak?
Mak dia tak ada sakit apa-apa.
Ingat tak ayah dia tu diagnose kencing manis umur berapa ya?
27 tahun.
Okay, lagi. Nur Ina Imani Saiful Nizam.
Puan, adanya ada tanda-tanda macam infection tak dekat pelipat-pelipat kulit pun, macam kat siku, kat dada, kat bawah.
Tak ada. Tak ada.
Tak ada.
Examination, satu last. Examination. Patient macam ni, you mesti kena check.
Ada jangkitan tak dekat bahagian sulit? Contohnya ada keluar discharge ke?
Tak ada.
Ataupun gatal-gatal?
Tak ada.
Lain. Ada satu lagi penting. Examination yang you kena buat.
Dia ada sakit perut tak?
Tak ada.
Kat perut dia sakit tak?
Tak ada.
Apa you nak check kat situ?
Tu pula DKA. Ada benda tenderness. Ada benda pain.
Unlikely ada DKA. Tak apa. Okay, lagi? Benda lain dekat abdomen. Examination, apa dia? You kena check. Nurul Atilah, cepat. Examination apa yang kena check?
Abdomen striae.
Striae, okay, lagi. Striae, okay, boleh lagi. More important than that?
Truncal obesity.
Yang tu, okay. Yang tu tak payah check, tak apa, tengok pun tahu dah. Okay, lagi.
Hepatosplenomegaly.
Hepatomegaly lah. Nak check for fatty liver kan. Takut dia ada fatty liver disease. This obese kan? Very obese.
Yes, very obese.
Okay, so fatty liver disease. So ada hepatomegaly tak?
Tak ada.
Tak ada, betul eh?
Dalam mention tak ada.
Okay, good. Okay. So Nurul Husna, cuba summarize case ni.
Patient 11 years old, ada underlying hypertension and he has symptoms of history of swelling, which reduced by antibiotics, and he has underlying hypertension. Currently, he also has acanthosis nigricans. However, there is no symptoms of hyperglycemia, such as polyuria, or he has polydipsia, but there's no polyuria. And there are no features of Cushing disease, such as abdominal striae or moon faces.
Dah tu je?
And he has no features of chronic chronic liver disease, such as hepatomegaly, or features of CLD, such as spider nevi, but we didn't ask about that.
Tak tanya pun. Okay, good. So I want full diagnosis from Sarah Nasuha. What is your diagnosis?
Patient might
Full
have
diagnosis 5 markah kan? This 5 marks punya diagnosis kan?
type type 1 diabetes mellitus with underlying hypertension and obesity.
Type 1. Anyone agree? Everyone agree? Kena I open pada sesiapa je lah. Okay. Everyone agree ke? Type 1 DM with hypertension and obesity.
No, I think it's like type might be that type 2 DM because of
Because apa? Sambung. Ada.
Kitty nak tanya ke?
Tak apa, Aini cakap lah.
Okay, what I mentioned type 2 diabetes mellitus because she had he is obese and had strong family history of diabetes mellitus and the onset of type 2 common onset of type 2 diabetes mellitus is at adolescent and young adult.
Yeah, common type 2. Adolescent and young adult.
Ya, betul.
Yang adult umur 20 tahun kan? Is it common ke 20 tahun diagnose diabetes? Type 2 diabetes 20 tahun ke?
It's actually more less.
Adolescent umur apa? 16, 17?
18.
Adolescent 18 Macam young adult 18. Adolescent?
Secondary school.
Secondary school is adolescent kan? Normal ke adolescent diagnose type 2 DM?
No, the age of onset.
Age of onset. Okay, boleh lah. Okay, lagi. Dah compare dengan type 1 kan? Memang lah. Okay, lagi.
Yes.
Okay, everyone agree ke diagnosis tu? That is still not complete lah. Apa dia? Yes.
I want to ask because this patient, her father is diagnosed with chronic disease such as DM hypertension at 37, which is considered as a young 27, which is considered as young age. Can it be a risk factor for these children?
Yes, definitely risk factor. So that information is very important. So what will it affect your diagnosis? Could it be something else ke? Ayah dia 27 dah dapat diabetes.
Could it be inherited?
Type 2 DM inherited ke?
No. Ada diagnosis.
Type 2 DM tak inherited. Which one is more apa tu? Inherited lah. Which one has stronger family history? Type 2 ke type 1?
Type 1.
2 ke type 1?
Type 1.
Type 2.
Siapa kata type 1?
Type 1.
Saya.
Jawapan type 2 Type 2 is more has stronger family history. In fact, kalau one of your parents ada DM, kan, chances untuk you ada DM is up to 30%. Okay, kalau 2 parents ada DM, up to one parent 10%. About that lah. 2 parents, your chance untuk dapat DM is 30%. Kalau you ada siblings, up to 50%. Tapi kalau type 1 DM, kalau you punya parents, kalau you ada DM pun, chance untuk anak you ada DM is similar to normal population. Okay, which is sama dengan normal population lah. Maksud kalau kita kat Malaysia, risk untuk dapat type 1 DM is only about 1 in berapa, 1 in 100,000 kot. So 1 in 200,000 lebih kurang. Tapi kalau you dekat Norway kan, kalau you kat Norway, mungkin you kat Scandinavian countries, so chances memang lagi high lah. So 1 in 3,000. Okay, so type 2 DM is stronger lah. Kalau dia family history of diabetes, chances are this is type 2 DM. Okay. Tapi kalau dia very strong family history of young diabetes, contoh
Doktor tak dengar.
Doktor tak dengar, termute.
okay, apa tadi okay. So what are the clues in this patient yang can help you with your diagnosis?
The family history.
Okay, so number one is strong family history kan, ada father. Tapi okay, back to our previous discussion kan. Kalau you ada parents yang both parents ataupun very strong family history, nenek umur 20 diabetes, mak 20 diabetes, and then anak diabetes, adik-beradik ada 3-4 orang diabetes, very young onset. Tapi not that severe, maksud dia very young onset diabetes, tapi nenek tak adalah sampai potong kaki, tak ada complication, mak pun tak ada complication, and semua on metformin, on sulfonylurea lah, mainly sulfonylurea, and well control. Tapi memang ramai dia diabetes. So usually this is what? Type 2 ke? And diorang tak ada obese sangat. Biasa tak obese lah. What kind of diabetes is this?
MODY doktor.
Possible dia MODY lah kan. Maturity onset diabetes in youth kan. So these are possible lah. Kalau so dia ada two different picture. Kalau you ada both family kan, mak ayah diabetes, obese, ada families of obesity, diabetes, and then ada metabolic syndrome, then chances are this is type 2 DM. Tapi kalau the patient itself tak gemuk, and then very strong family history, young onset diabetes tapi yang tak complicated, biasanya this is MODY lah. You have to think of MODY. Tapi kalau no family history, tiba-tiba dapat DM, very young age, chances are majority is type 1 DM. Okay. Lagi apa lagi? What are the clue in the family yang in the history yang kata this is type 2 DM? First, family history. Second, more important than that is
obesity.
Obesity, good. So number 1 family history. Number 2 is obesity. Number 3 is yang very pathognomic. Basically kalau dia ada benda ni memang akan terus nigricans kan. There's evidence of kenapa dia ada akan nigricans? Yes, insulin resistance. Okay. So patient ni ada insulin resistance, evidence of insulin resistance, dia obese, strong family history, so diagnosis you mesti type 2 DM. Okay, you tak boleh tak, kalau dah exam, kalau you tak type 1 DM, memang akan fail kan lah. Saya salah, I akan bagi salah. Kalau you tak DM alone, you dapat separuh markah. Tapi kalau you tak type 1 DM, memang akan salah lah. Okay, this is a confirmed type 2 DM. Okay, you don't need any blood investigation, antibody ke, untuk confirm. By this, you boleh kata this is type 2 DM. Okay, in clinical pun kita tak investigate further lah. Kita tahu ada characteristics, obese, strong family history, memang this type 2 lah. And then kalau ada features of metabolic syndrome such as apa features of metabolic syndrome?
waist circumference for male more than 90, blood pressure high,
Good.
systolic blood pressure more than 130 and above, and or diastolic pressure more than 85 or more, and then fasting plasma glucose 5.6 and above millimole per liter, and triglyceride 1.7 and above, and then HDL for male less than 1.0, female less than 1.3. And to diagnose metabolic syndrome, they need at least 3 from waist 3 out of these 5 features.
Okay. Okay, good. So yang ni in adult lah kan. In adult BP kita guna 130 over 85 lah. 135 over 85 atau 140 over 90 untuk hypertension kan. So in pediatric you kena tengok dia punya height percentile dia lah. So in general patient ni ada features of metabolic syndrome. Which is ada central obesity, and then dia ada evidence of insulin resistance, BP, hypertension, young onset hypertension. So the diagnosis would be, okay, the correct diagnosis in this patient would be type 2 DM with underlying obesity and young hypertension kan. Complicated with infection lah kan, skin infection. Betul tak?
Tapi doktor, infection dia dah resolve.
Lah, tapi waktu infection tu dapat ni kan, dapat dia tahu diagnosis waktu infection kan. So macam tu lah. Okay, ada soalan?
Doktor, saya ada question about yang infection tu kan. If the patient complain dia ada swelling tu, is it because of abscess or kebangkel?
Macam nak beza, apa beza kebangkel? Dia kan buat surgical ke? Dah buat kan?
Dia ada banyak puncture. Kebangkel.
Apa? Selain daripada kebangkel, apa lagi you tahu?
Ferangkel.
Ferangkel kan? Ferangkel, kebangkel lagi. Itulah, mainly itulah yang tu yang in terms of pore kan, sweat pore memang tu je lah. Ferangkel, kebangkel. Tapi abscess, apa beza dia abscess? Ni dah surgical lah, I rasa tanya surgeon lah. Tapi in general, abscess is deeper daripada ni. Ferangkel, kebangkel is more superficial lah, dia dekat epidermis layer. The abscess dia deeper. Tapi better you confirm dengan surgeon lah, I kan surgeon. Okay, lagi? Ada soalan lain?
Doctor, for Modi, beside very strong family history dan disease dia tak complicated, ada lagi ke macam how to diagnose clinically Modi?
Okay, clinically dia in general dia tak obese. Okay, dia tak obese. There's no acanthosis nigricans. Okay, dia tak ada evidence of insulin insensitivity lah atau insulin resistance. So dia tak ada acanthosis nigricans. And then dia bukan type 1. Modi ni is diagnosis for exclusion. Okay, in general. You boleh confirm by genetic study lah because it's a monogenic autosomal dominant DM. You boleh buat genetic testing untuk confirm, tapi by clinical you rule out type 1, you rule out type 2, you Modi. Macam tu lah. So unless kalau you less than 6 months, then you jadi 2, then you akan jadi congenital diabetes lah, neonatal diabetes. Dia transient atau permanent tu tak pernah. So Modi, so prinsipal dia, you kena rule out type 1. Type 1 apa features type 1? Dia biasa thin kan, dia biasa kurus. Ada DKA, initial presentation with DKA. Okay, biasa Modi dia tak ada DKA, sebab dia still ada insulin. Okay, so type 1 dia ada DKA. Type 2, they can present with DKA at diagnosis. But rarely they can present with DKA at diagnosis. Adult more common, tapi in pediatric rarely lah dia akan present with DKA at diagnosis. Tapi they can. So kalau dia ada contoh type 2, dia mesti obese. So budak ni dia mesti Modi lah. Modi dia mesti tak obese, dia mesti tak gemuk. Dia mesti tak ada acanthosis nigricans. BP dia usually normal. And then dia tak ada DKA, representation. Very strong family history. Macam tu lah. Faham tak? Dia tak accept exclusion. Okay, faham kan?
Thank you, Doctor.
Okay, and then by blood, okay, investigation. Apa yang you nak buat? Investigation.
First, I would like to do the random blood glucose and HbA1c to look for HbA1c to assess the control of the glucose for the past 3 months. And then the full blood count because he had came with a sign of infection. And then lipid profile to assess the risk of this lipidemia. And then the renal function test to look for any evidence of nephropathy by impact the kidney function. And then the liver function test to screen for any liver damage in view of the childhood obesity. And then the ultrasound of the abdomen to look for any fatty liver, evidence of fatty liver.
Okay.
And then UFME to look for any presence of proteinuria in nephropathy.
Okay, good. Okay. Dia kan bila when you talk about investigation kan, you kena susun investigation first line, second line, third line. That's the way you approach. First line is investigation that will help you to diagnose. Okay. The first line yang basic investigation yang akan help you with diagnosis. And then second line yang akan confirm diagnosis. Akan confirm diagnosis atau yang second line lah yang tak routinely done. That's how you approach lah. Ataupun you boleh buat investigation first yang to confirm diagnosis. And then to detect complication. The second investigation you arrange is those yang akan detect any complication. Ataupun those yang akan give you information on prognostication. You faham tak? So first is diagnosis. Macam you nak diagnose DM. So Marhani sebut tadi kan. Apa dia? Fasting.
Plasma glucose.
Fasting kena berapa?
Fasting more than 7.0 or more millimole per liter.
The 7.1 and more lah. Dia mesti more than 7.0 lah. 7.1 and more. Fasting lagi. HbA1c berapa? Kau nak diagnose DM?
More than 6.5%.
Okay, more than 6.5 percent. Okay lagi. So criteria diagnosis first, dia mesti ada symptoms plus fasting. Ataupun symptom plus random more than
11.1.
11.1 kan. Random more than 11.1. Okay, ataupun symptoms plus HbA1c more than 6.5. Okay. Lepas tu apa lagi? Ataupun apa lagi you boleh buat? You kena list down lah semua. Apa lagi? Macam mana nak diagnose? Symptoms plus OGTT. So OGTT nak bagi berapa gram sugar?
75 gram.
75 gram kan? 75 gram sugar. And macam nak confirm diagnosis OGTT?
The 2-hour postprandial. 2-hour post sugar.
Berapa?
More than 11.1. The same as plasma glucose.
Okay, good. Okay. Kalau dia less than 11.1 tapi dia more than 7.1? Ya, 7.1.
Impact glucose tolerance.
Lipid.
Impact fasting glucose kan? Impact fasting glucose tolerance lah. Impact fasting. Okay, tak apalah. Tu diagnosis lah. Okay, sekarang you dah diagnose. Pasal apa you kena buat? Apa lagi? Apa yang you kena buat lagi? Patient datang dengan you with uncontrolled sugar. Uncontrolled sugar. So apa yang you kena buat?
So like the test mentioned, to detect the complication from the disease. So we can do renal function test.
You nak tengok apa?
To look for the creatinine level.
Okay, look for creatinine level kan? Nak tengok level CKD lagi?
Lipid profile.
Lipid profile, fasting lipid ke?
Fasting lipid, yes.
It doesn't matter actually, it doesn't matter.
Oh.
Kalau fasting lipid, kalau random lipid tu inconclusive, then kita buat fasting. Tapi kalau random lipid dah memang confirm, then you tak perlu buat fasting pun sebenarnya. Okay, tapi ideally fasting lah. Kalau tak, you boleh buat je random. Okay, lagi. Fasting lipid profile nak tengok apa?
Look for the HDL and LDL level as well as triglycerides.
Okay, so mainly tengok LDL lah LDL dan triglycerides. HDL kita tak concern sangat lah. Okay, lagi? Apa lagi?
Liver function test. To
Liver
look any
function
for
test.
liver increase in liver enzyme.
Okay, so kenapa?
Look for any fatty liver.
Okay, fatty liver disease. Okay, fatty liver disease. Lagi apa lagi? Apa lagi yang you perlu investigate?
So we need to do renal abdomen ultrasound.
Okay, kalau ada derangement kalau ada derangement buat ultrasound. Kalau tak payah buat lah. Okay, to look for fatty liver lah, fatty infiltration. Okay, lagi apa lagi? Complication lain.
And then fundoscopy to look for any because type 2 diabetes we have micro and macrovascular complication. So micro is microvascular complication, retinopathy. So we need to do fundoscopy to look for any evidence of retinopathy.
Okay, good. Lagi? Acutely apa yang kena check? Kalau patient datang acute complain. So apa yang kita kena check?
Urine for ketone.
Okay, good. Urine ke blood ketone better? So back to your basic sciences lah. Blood ketone is better lah. Ada berapa jenis ketone? Ketone body ada berapa jenis?
2.
Ya, 2. Apa dia 2? Ada 3 kan? Apa dia 3?
Tak ingat.
Aceton lagi? Okay, lagi? Okay, Luqman, I nak you check 3 ni, and then dia punya physical property of this ketone body, and then you share dengan I dan share dengan your friend. Okay, okay, so ideally you buat blood ketone lah kan? Selain blood ketone, apa yang kena buat? Patient datang dengan acute hyperglycemia. Okay, blood gas nak tengok apa?
To look for pH, metabolic acidosis.
Okay, good. Nak tengok pH kan? Okay, lagi? Anion gap lah satu. Nak tengok pH, nak tengok anion gap. Okay, lagi? Apa lagi nak kena buat? Kita tak tahu dia DKA ke tak kan? Satu apa dia complication? HSS kan?
Serum osmolality kata.
So you nak kena atas serum osmolality. Okay, good. Okay, lepas tu ketone you dah check, negatif. VBG, no acidosis. Osmolality, normal. Then you okay lah. Tapi kalau contoh ada yang sakit, at the end your diagnosis should be newly diagnosed type 2 DM with underlying obesity and young onset hypertension, complicated with apa dia? Kalau dia datang acute crisis kan, so you diagnosis should be HSS with underlying newly diagnosed, HSS with newly diagnosed, ataupun DKA with newly diagnosed. Okay, faham? So that should be your diagnosis lah. Kalau 5 markah punya diagnosis lah, atau 10 markah punya diagnosis, saya boleh juga buat 10 markah diagnosis. Okay, faham? So that's how you put your diagnosis. Okay, rasa tu cukup. Ada soalan? Management, okay, management lah, 5 minit. Management. How do you manage?
For the management to this patient, the aim of management, we need to optimize the blood pressure and glucose level. So for the optimization of blood pressure, we need to the patient continue the the medications and need to advise on to the compliance of medication. And then for the glucose, can start on tablet metformin, and then refer for this patient to the dietitian for diabetic diet.
Okay, good. Lagi?
And then
Exercise lah kan? Exercise.
yes.
So in general you boleh bagi division, it's good lah cara you answer. So start dengan you first kali sebut the aim of management. So the aim of our management is number one to optimize the glucose control. Number two, to control the BP. Number three, to kalau you tahu dah dia punya lipid profile semua kan, to reduce the HDL, LDL ataupun triglyceride level. So you will sebut aim you. First you sebut aim. Okay, and then management can be divided into apa dia? Pharmacological dan pharmacological. And then pharmacological apa? You bagi metformin untuk sugar. Okay, you will justify kenapa bagi metformin? Kenapa tak bagi benda lain? Kenapa tak start insulin? Kenapa tak start insulin?
Because the insulin needs more the care for insulin is more specific. So we start metformin and the blood the level of the blood glucose.
Okay.
Increase insulin sensitivity.
High risk for hypoglycemia.
Okay, good. Okay, so banyaklah antara factors dia kita kena balance. So you boleh dalam discussion you sebut kenapa tak start insulin, kenapa kita start metformin. You boleh justify lah. Metformin sebab dia ada property dia reduce weight kan. Metformin reduce weight, dia increase insulin sensitivity kan. Lepas tu dia no risk of hypoglycemia, low risk of hypoglycemia. Okay, so kalau budak ni and then we can dia less painful, less invasive, hopefully better compliance kan. Less difficult lah, technically easier untuk administer. Kalau insulin apa dia punya problem dia? Insulin bagus sebab dia boleh rapid glucose control, selalu in crisis lah kita akan bagi patient ni nampak stable. So tak perlulah insulin. Besides, tapi insulin punya complication apa?
Weight gain.
Weight gain, good. So weight gain kan, patient dah obese, kalau tu bagi lagi weight gain. So tak berapa bagus lah. And then second is hypoglycemia tadi kan, sebut hypoglycemia tadi. So patient is still growing child lah, 11-year-old still a growing child. So hypoglycemia is not good lah for them. So kita tak nak hypoglycemia, and because they're still growing child, we won't be too ambitious lah untuk to reduce the HbA1c. So kita aim slightly high dan 6.5 to 7. Kalau budak besar kita nak 5.5, 6. Okay, tapi kalau budak macam ni 6.5 is okay lah to 7. Ideally 6.5. Okay, lepas tu apa lagi ya? So that's pharmacological. Lagi pharmacological apa? Control the BP to prevent long term complication. So BP should be aimed between blah 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 blah. Okay. Lepas tu by medication lah, patient on medication. So biasa kita bagi ACE lah untuk budak kecil. Kenapa tak boleh tak bagi apa oral antidiabetic lain yang kita boleh bagi? Patient 11 tahun. Apa OHA yang you tahu? Metformin.
Sulfonylurea.
Boleh tak bagi sulfonylurea kat budak ni? Okay lah, in general kan, the only OHA yang kita boleh bagi kat budak-budak less than 14 years old is metformin. Yang lain semua tak license. So you tak ada choice lah, you cuma beri metformin je. And then second choice is insulin. And then you boleh tambah dengan GLP-1 receptor agonist. Macam liraglutide semua tu lah, which is Yang tu injection lah. Again dia daily injection. OM injection. And tak rasa ada kat Malaysia ni. Kalau ada pun mungkin kat private ada kot. Kat UIA tak ada lah. So tu je yang ada kat budak-budak. So simple. DM budak-budak, management is metformin, insulin. Tu je. Dia tak sebutlah benda lain. So non-pharmacological macam diet, exercise, healthy lifestyle, benda macam tu lah. So you boleh goreng lah benda tu. Okay, lepas tu kalau patient ni LDL dia high, you bagi. Cholesterol high, LDL high, you bagi? Statin, good. Okay, kalau triglyceride dia high, you bagi?
Fibrates.
Yes, good, fibrates. Tapi fibrates rasa macam tak license untuk budak-budak. Boleh check lah, rasa macam tak license. Biasa tu bagi statin lah. Tapi kalau predominant triglyceride high, then you bagi fenofibrate lah. Triglycerides high, maksud dia makan simple sugar. So you kena make sure diet dia reduce simple sugar dalam diet. Ice cream, gula-gula, things like that. Tapi kalau dia LDL high, triglyceride low, biasanya dia makan complex sugar. So you kena reduce diet dia of complex sugar lah. Artinya macam nasi, reduce portion nasi. Tambahkan dia punya vegetables. Okay, fibers. Itu je lah kot. And then the third management tadi is, second management tadi, prevent complication kan. By education. Okay, medical, kita ada satu term dia medical nutritional therapy, MNT. Okay, in diabetes dia ada non-pharmacological, which divided into lifestyle, MNT, medical nutritional therapy. You should use this term dalam your discussion. So MNT, lifestyle changes, exercise, yang itulah. And then education, medical education, including compliance, compliance to medication, avoidance of high risk behavior macam smoking. Macam tu lah. Okay lah. Itu je kot. Ada soalan? Last.
Dr. I want to ask, for trial patient, we start with non-pharmacological first and then we continue with pharmacological, or we start it together?
Kalau patient macam ni, you kena start metformin dulu. Start together lah, you start together, tapi definitely you kena start pharmacological. Kalau tak, dia tak, the A won't works. So you start metformin and then you hentam ada, hantarlah physio ke benda.
Okay, thank you, doctor.
Is it because the patient have complication, that's why we start with pharmaco terus?
Oh tak, sebab kalau patient dah confirm diagnosis, you boleh guide by your HbA1c lah juga. Contoh HbA1c dia dah 9, 10, then you kena pharmacological lah, kalau tak dia takkan jalan. Unless kalau HbA1c dia baru 6 ke 7, then you may consider lifestyle lah. Tapi let's say kalau dia dah ada comorbid, dah start ada hypertension tu, chances are memang you kena start pharmacological. Because metformin good lah, because dia reduce weight, increase insulin sensitivity. It's a good start. And then most people tolerate. Cuma you kena careful. Bila you start tu, you kena advise on GI symptoms, benda macam tu lah. Okay. Okay lah, rasa tu je lah. Kalau ada soalan, you boleh tanya later lah. Okay. Kita tangguh dengan tasbih kafarah. Okay.
Okay, thank you, doctor.
Thank you, doctor.
Thank you so much, doctor.
Thank you, doctor.
Assalamualaikum.
Terima kasih, doktor.